Good evening, everyone, and thank you all for joining us for tonight's COVID-19 update webinar. My name is Beth, and I am joined tonight by our presenters. We have Associate Professor Charlotte Hespy, Associate Professor Penny Burns, Dr. Kerry Chan, and Dr. Kataki Sharma. So before we get started, I would just like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. I'm now going to pass you over to Dr. Kerry Chan to provide us with an update.
Thanks very much, and I too would like to acknowledge the traditional custodians of the land on which we're meeting and pay my respects to elders past, present and emerging. Probably just to summarise where we are with our epidemiological situation, we have no community transmission across Australia, and as I understand it, all our borders are, I think, open at this stage between us. We've clearly had two incursion events, two clusters of disease originating in Queensland, and New South Wales was touched by one of those when we had a gathering in Byron, which did lead to transmission to a number of people who attended a party at Byron. We saw one subsequent transmission into a person who also attended a hotel at the same time those infectious individuals were present in Byron. But we've had no further evidence of transmission. We're now at 14 days and the majority of people have now been released from quarantine. So that highlights sort of, I suppose, the strong response Queensland had in investigating their cluster and also the response that occurred in northern New South Wales. The vaccine rollout continues, and we've vaccinated a large percentage of our quarantine workers, almost 100% of them at a point in time. Obviously, there's new entrants all the time. And we've also rolled out a significant proportion of COVID vaccines to our 1A and 1B healthcare workers, again, providing that ring of protection so that we prevent any community incursions. The aim is really to have a period of no community transmission whilst we roll out the vaccine, and I'll leave it to Kataki. I don't need to tell you what's happened recently in relation to the new ATAKI advice last week in relation to the AstraZeneca. But in summary, we have no community transmission. We're hoping to maintain that, but we're obviously always vigilant that we may see these incursion events. And I think the fact that New Zealand is dealing with some transmission from quarantine, and we had the two clusters, two separate distinct clusters in Queensland, again highlights that this threat, the introduction of COVID, will remain with us. Thank you.
Thanks, Kerry. Kataki, did you want to say a little bit about the situation as well?
Yeah, sure. And if it's okay, I do have some slides that I can share, which I stole from Christine. So I'll just hopefully bring up. Okay. Are you able to see my PowerPoint slides?
Yep.
Yes,
do you want to do it, if you do it on slideshow, so then we get a bit more detail on there?
Yeah. Is that working?
Yep.
Okay, great. So as I said, I stole these from Christine, but I thought everyone would be interested in an update on this particular issue. So the entity has, we are calling it, or ATAGI is calling it, thrombosis and thrombocytopenia syndrome. The Brighton collaboration is actually right now deliberating on a formal title, but this is likely to be one of the contenders. And what we know about this condition is it's a new entity. I've seen a couple of questions already in the chat about the background incidence of CVST and immune thrombocytopenia. And the person in the chat is correct that we don't really have good data on what a background rate of CVST is. But even so, this appears to be a different pathophysiology and a completely new phenomenon. So what it's presented with is significant thrombosis. The common locations seem to have been the central venous sinus and also intra-abdominal veins, but it can also be arterial, associated with thrombocytopenia. So all of these reported cases overseas have had thrombocytopenia. So people who have, for example, a DVT temporally related to their vaccine are unlikely to have this particular phenomenon. It really needs those two elements. And the typical lab features that have been seen in the cases overseas include platelet count below 150 that then drops and it can be severe. Some cases have been associated with bleeding. Very high D-dimer levels, up to 5 times the upper limit of normal, and inappropriately low fibrinogen levels. And in many of the cases where testing has been available, they've found anti-PF4 antibodies. And this is a type of an antibody that has been seen in a condition that is thought to have a similar pathophysiology called heparin-induced thrombocytopenia. And that's why you might have seen the precautions for people with a past history of heparin-induced thrombocytopenia or HIT and CVST, because they appear to share similarities. But as hematologists learn more about this particular entity, it does seem to be distinct from both of those. And for example, when they looked at the serum of people who had TTS and the serum of people who had heparin-induced thrombocytopenia, they responded differently when they added heparin. So the people with TTS, their platelets were already activated even in the absence of heparin, and didn't necessarily react even further with addition of heparin, whereas it was straightforward, it was induced with heparin in the people with HIT. So it seems to be something new. It is potentially severe. So the UK reported cases of about 79 total cases had a 25% case fatality rate. And at this stage, obviously, if there's a new entity, a lot of those cases were elicited retrospectively after discovering this phenomenon. So we don't yet know the impact of early detection and early diagnosis, and hopefully that is going to contribute to a lower mortality rate now that there is awareness of how to detect and treat this condition. And the onset or the high risk period appears to be between 4 to 20 days after vaccination. Importantly, all of the reported cases globally to date have been after the first dose of the AstraZeneca vaccine. And this is, in the UK alone, there's 3 million people who've had their dose too, and there have been no cases. So this is really reassuring for those people who've already had their first dose of AstraZeneca, that they can go ahead and have their second dose. And we don't have any reported cases of a case after the second dose. So in terms of investigation and treatment, we do have at the end of that line there, Sands, we have our Australian Thrombosis and Hemostasis Society guidelines, which are available online. They've provided guidance on which initial investigations to do, and then if a case meets criteria, to refer on for further hematology investigations. The treatment that's currently recommended is IVIG and possibly steroids. And as I've said in the bottom line below, saying people who have sort of straightforward DVT without thrombocytopenia, they're very unlikely to have this particular condition. So just to summarize the rationale behind ATAGI's decision, we can see that this is an extremely rare condition. The cases that have been seen overseas have occurred in all ages and genders, and there is no specific predisposing factor that has yet been confirmed. However, in the UK, there is a trend of increasing rate of TTS with decreasing age. And that is partly why this recommendation was made, that there should be a preferential vaccine for people under 50. There is a need now to raise awareness for informed consent, clinical management and surveillance. And we do have a greater supply of AstraZeneca vaccine now. The individual risk benefit analysis is clearly better for older adults. And I'll show you the UK slides you may have seen, but clearly the risks from COVID-19 rise I think the mortality rate rises 3 times with each decade increase in life. And so therefore the risk benefit analysis favors vaccination the older you get. And disclosure of the vaccine link with TTS has potentially dented vaccine confidence and led to policy change in several countries. So the key policy points from ATAGI recently are that AstraZeneca is still registered and recommended in all adults. The preference for Pfizer is only in people under 50. And for those people, we need to ensure that they have the opportunity to still get this vaccine with informed consent. And part of the reason this was a very difficult decision to make, because people perceive risk differently. Some people think a 1 in 200,000 risk, that's not a big deal, I'm happy to go ahead. Other people want a lot more information. And so this particular decision was intended to provide at least some guidance, so that to make it easier for GPs to help people understand the risks versus benefits. So I'll just skip ahead. I'm not going to go through all of these slides. So I think I've already covered all of this. For people under 50, it's important to consider their risk factors for exposure to COVID or for severe illness from COVID, because they might actually tip the balance in favour of vaccination. And so we still have to remember it's not that people under 50 should not be vaccinated or are not recommended to have AstraZeneca vaccine. It's just a preferential recommendation. So there's certainly people for whom the risks of COVID are far greater, and they would, with informed consent, still benefit from vaccination. The updated advice now is that community, the Pfizer vaccine, is preferred for people with a past history of HIT or CVST. Previously, ATAGI had recommended as an extreme precautionary measure that people with this past history should have no COVID-19 vaccine. Now that it's clear there is no signal for community, looking at data from the US where tens of millions of doses have been given, it is not associated with this TTS, and so therefore community is safe for people with these two conditions. But also there is no evidence that a past history of HIT or CVST increases your risk for TTS. So AstraZeneca vaccine is not contraindicated in this group either. There is no evidence that other clotting tendencies will increase your risk of TTS. So there is no signal for an increase in the rates of any other type of common thromboembolic conditions or immune thrombocytopenia in the countries that have extensively used AstraZeneca vaccine. As I've mentioned, people who've had their first dose without any issue can have the second dose. And people who have had anything that's suspicious for thrombocytopenia and thrombosis after their first dose should obviously not have their second dose. This advice will be updated as further information becomes available, but also if our epidemiology changes in Australia, because obviously this decision was made in the context of low or no community transmission, and that has a significant impact on the age-specific risk-benefit assessment. Just showing you here that the Thrombosis and Hemostasis Society have published a guideline if anyone wants to have a look for more information about how to investigate and treat this condition. And they also have a list of local contacts for each state so that you know which lab to refer to. I won't go through all of the country-specific data because there's probably not enough time, but I'll just show you this slide. So similar data is being prepared for Australia in a similar graphic sort of presentation that can be shared with patients to help them understand the risks of ICU admission from COVID-19 compared to the risks of serious harm from the vaccine. And as you can see in the UK, with a low exposure risk, the risk benefit assessment favoured not getting a vaccine if you are under 30 years of age. So it's when you look at it this way, it's quite a rational decision. And so as your risk of exposure increases, that changes. And clearly in a high exposure scenario, everyone should be getting vaccinated. So as I said, a similar sort of framework will be developed to show with patients and to make it easier to sort of go through this risk benefit matrix, taking into account all of the other individual factors. So that's my summary slide. I think I'll stop there because I don't want to take up too much time.
Thanks, Kataki. That's great. Look, can we just sort of highlight and clarify a few of the things you said, just so I know that some of the questions have come in, you've already answered, but I think it would be really nice to just go through them and make sure that we've got them all really clearly spelt out. So in terms of who shouldn't be having AstraZeneca vaccine, what are the absolute contraindications? And then when we get to clotting complications, what do we have to consider there?
So the absolute contraindications haven't really changed. So as before, someone who's had an anaphylactic reaction to a previous dose or to a component of the vaccine. The only new contraindication is if someone is suspected to have had this condition, thrombosis with thrombocytopenia after the first dose. And so if someone had temporally related to their first dose, if they had an episode of ITP 2 weeks later, or they had a DVT 2 weeks later, that is not a contraindication. Of course, that individual might not want to proceed with the second dose, but there's no evidence on which to say that that would be linked to the vaccination. As you've seen in the slides, it clearly does appear to be a distinct entity from other causes of thrombocytopenia and other causes of thrombosis. So the contraindications are otherwise unchanged.
And then would you...
Sorry, can I just clarify that you're saying that the previous advice that we were telling to have patients who had had previous episodes of the heparin-induced thrombocytopenia and or a cavernous sinus thrombosis no longer is the case because this is a distinct entity not related to those things. And I think that's really important because I hadn't gathered that before tonight.
Yes, yes, and that's understandable because a lot of the provider information materials are, soon to be published, but that will be clearly specified. So it's no longer a contraindication, but still a preferential recommendation that if you've had those two conditions, CVST or which someone asked what they stand for, so cerebral venous sinus thrombosis or heparin-induced thrombocytopenia in the past, it is preferred to have Comirnaty, the Pfizer vaccine. And that is, again, just based on extreme precautionary theoretical concern that there might be some links. But I think in total globally, there's been over 180 cases of this condition detected, and they haven't found any risk factors. So the people that have had this condition haven't had an increased risk from past CVST or from other clotting tendencies.
And then the other really important one is that there is no association with the second dose, which again is a very reassuring sort of piece of information that you've had it safely, you can go ahead with number 2.
And so
Absolutely.
Kataki, I just want to triple clarify it for everyone because it is kind of new. So I've got a patient, they're over 50. They've come in, they've got a past history of CVST, they've obviously recovered. And they really want to have the AstraZeneca because they're going to wait months to get the Pfizer. I can happily and confidently go ahead and ask them, give that to them.
Yes, with informed consent that
with
this
informed
condition has
consent,
been identified, and
Yeah, and I think that's really important because on the new consent form that's come out, they are separated out as items, and I think a lot of us sort of think, oh, okay, that means that they're, we have to be really careful not to give it. So I think that's really, really important. And can I ask, going back to Charlotte's question around the second vaccine, what is the rationale behind that? If you haven't had the reaction to the, that safety, that confidence, absolute confidence around getting the second AstraZeneca vaccine, if you didn't have a reaction to the first?
Just because of the millions of second doses that have been given, and not a single case has been reported after a second dose. And so, as we've heard from Kerry, the risk of COVID hasn't gone away. So if we could be guaranteed, for example, that our borders would stay locked for 2 years until we all got enough Pfizer, these guidelines might be different, but we've got to balance the risk of potential exposure. And so therefore, looking at the fact that there's never been a case reported yet after a second dose, really favours vaccinating these people to make sure they have longer term protection against COVID, particularly people older than 50 who have the higher risk of severe illness from COVID.
Can I also
sorry, I was just going to say one last thing, just when talking to patients, and I know you're all very familiar with this because you do it absolutely every day, when vaccine safety issues arise, people are often very preoccupied with talking about the vaccine safety issue and sort of forget to factor in the risks of the actual vaccine preventable disease that we're trying to prevent. So
I think definitely have that conversation. Just to clarify what the actual risk that we state at the moment, that we know that it's emerged anyway.
So that is likely to change. At the moment, the figure that ATAGI is quoting is 4 to 6 per million. But obviously, there's further data being accumulated from other countries. There are case series that have been published. There was a case series from Norway that was published in the New England Journal of Medicine that reported a higher rate. They had 5 cases in a population of about 130,000. So it's not known if that's just luck or chance, or if there's some other explanation for that. But certainly from the bigger data sets, looking at the EMA data, the UK data, and AstraZeneca safety database, the figure being quoted is 4 to 6 per million.
So Kataki, can I then ask you about adolescents and children and what the progress is there? So we're worried about this in younger people. So what's happening with the AstraZeneca testing in adolescents and children? And
so my understanding is they've suspended their trial in children, and I think the UK, as you would have seen, even in the context of having circulated COVID-19, have put in a recommendation that people under 30 should preferably have another vaccine. So I think Australia, if and when a COVID-19 vaccine is registered for people under 18, if it was the AstraZeneca vaccine at the moment, it might be a similar recommendation. just because of that, they have a much lower risk of severe illness from COVID-19. But in other vaccines, Pfizer have had a press release with 100% efficacy in adolescents for their vaccine. So that's fantastic news. So there will hopefully be a vaccine available for children and adolescents.
Can I then just dive a slightly sideways, if that's okay, and maybe Kerry can add value here as well, Kataki. If we're then looking at Pfizer, I've been hearing that Pfizer is much less needing to be, at the -70 and is not as anti-general practice vaccine clinic as initially thought. Do you think down the track, once we've sort of rolled out all of the 50s and overs, that there might be a role then for general practice helping with Pfizer as well?
Charlotte, I think that what you're referencing is the fact that we know that Pfizer can be stored for a period of time at -20, which is more of the normal freezer temperatures, not the special freezers, down to -70. And we also know that it can be stored in fridges for the period of in 2 to 8 degrees in for about 5 days. So operationally, there is the ability to sort of split packs and have that, but we still need, at the moment, there's still some ways in which it's packaged where the trays are a certain size, and you would need to get through those, notwithstanding the freezing and thawing components of it. So I think that it still does lend itself to that, but as we know, it may be that there's different packaging formats for Pfizer down the track. And I think also, Kataki, I believe that they may also be trying to develop more thermally stable vaccines. And so the generation of vaccines in the next, towards the end of the year may have other characteristics. And so it really is, let me tell you, a flexible rollout of this vaccine, because we're going to need to adjust. But many general practices may well be able to have significant throughput if they organise themselves to do so. So certainly splitting vaccines across multiple general practice, but it would need a level of organisation so that we weren't wasting vaccine if it was still in very scarce supply. But Kataki, did you want to say anything about those elements?
No, nothing to add other than this is sort of to be expected. That part of the reason that the vaccine had those ultra cold chain requirements initially is they wanted to just get it out as soon as possible before they were even able to get this data. And so hopefully, we'll see over time they might come up with a freeze-dried preparation or something that's even more transportable and storable.
And I think I understand that in the UK, there were GPs were actually rolling out some of the Pfizer vaccine, just based on what you said, Kerry, about the 5 days at better temperature.
That's right. So, I mean, it just requires larger practices or more organisation or more coordination across practices. It's not so. I think we need to keep a very open mind as we move forward in terms of what, we know that everyone's going to have to work together to get the rollout. And regardless of which vaccines, I think general practice is going to play a really important role within the constraints of the products and the logistics that go behind it.
So sort of moving with the conversation, I'm mindful this isn't a question I've seen in the chat, but I think we need to address it because it's been in the media a lot, is about the rollout for the aged care facilities. Is there any sort of plan at the moment with New South Wales Health in terms of what we're doing with the aged care facility staff and or sort of trying to get some of the aged care facilities done faster, or is that still something that's totally in the hands of the department?
Look, it's been pleasing to see that the Commonwealth's activity in aged care has ramped up, and I think that the estimate is around 6 to 8 weeks for them to, or a bit longer for them to complete it. So I think that they have made significant inroads, and we've seen an upswing in that, just as we've seen an incredible upswing in the rollout through general practice in the first couple of weeks you've had access to the AstraZeneca. So I think clearly aged care remains a priority. We know that the characteristics of the age profile, but also the comorbidities of the aged care residents means that they're going to suffer greatly if COVID gets introduced into those settings. And we also see aged care staff as a real priority. Again, we know once COVID is circulating in the community, it is actually very hard to keep it out of aged care facilities unless you've vaccinated the aged care staff, because obviously you need that workforce to maintain the function. And at any one time, there'll always be non-immune within that elderly population or those that are still susceptible.
So, Kerry, can I ask what the plan is around the aged care staff at the moment? Because I know that the residents are all being done.
So look, the Commonwealth is really working on what the recalibration of the program looks like, and they've been working through the weekend, just as the National Centre, I know, has been updating all of the decision supports into the wee hours. So everyone is really focused on this. I think it's important to remember this got notified, this announcement was made on late into Thursday night, and to some extent we've been into a response mode, and that was just when ATAGI handed over its advice. So I think that they're very important questions which we know we need to grapple with. I'm just indicating that I see aged care workforce as a key priority group. And the Commonwealth are doing some planning, and the states have provided, are here to support as well. So I think how it evolves will come in this next week. But again, can I highlight that as information changes, we'll have to keep on changing the program and responding to that. Some of the key variables are the characteristics of the products, the supply of the products. If we're in a non-constrained environment, then we can make different decisions than if we're in a constrained and prioritised environment. So I know that doesn't answer your questions, but I suspect that over the coming days we'll have a bit more clarity. But then, even then, it will, I think we have to accept that this will continue to evolve as we roll out the vaccine.
Yeah, and I know we were talking earlier, we had our first AstraZeneca vaccination clinic this Saturday, sort of several days after that announcement, and we did have a number of people withdraw, and we had to, but we managed to hunt around and get enough people. But I think one of the things we're learning out of that is that we may be focusing in our practice a little bit more on the flu vaccine rollout for the moment, while we're waiting to see what happens with the AstraZeneca. Kataki, I want to ask you a question that's coming up from a number of people on the chat box, is around mixing up doses. So if someone's had an AstraZeneca dose and really doesn't want to get the second one, will there be, can they get a Pfizer as a second dose?
I guess I can't advise on the booking and access side, but from a mixed schedules point of view, at the moment, there is no evidence on whether that would be effective. There is a bit of a difference between the AstraZeneca and Pfizer vaccines. So the Pfizer vaccine, the S protein is stabilized in its pre-fusion conformation. The AstraZeneca vaccine, it's not. So it's not the exact same, epitopes or molecules that are being presented to the immune system. So maybe that could have an impact on the immunogenicity. On the other hand, it might actually be a beneficial thing. So in the absence of that information, at the moment, the ATAGI does not recommend giving a different brand vaccine for the second dose. But as always, that could change once that evidence comes out. And in exceptional circumstances, so certainly if somebody has had suspected TTS, or if they've had anaphylaxis after the first dose, they should be given a second brand. But I'm sorry, I don't know about the actual, how do they go about booking into a Pfizer hub if they've had their first dose AstraZeneca?
I guess it came up originally. Oh, I was just going to say, I guess it came up originally with a few travellers coming from overseas where they've had their first Moderna, for example, or something else, and then having to rejig and give them a second vaccine. So it was more around efficacy.
I think a second dose of something would certainly be better than nothing. So if someone's come here having had Moderna, they should get probably Pfizer because it's another mRNA vaccine. So hopefully the closest thing. I can't tell you the content, but I can tell you ATAGI is actually developing guidance on mixed schedules that will be published very shortly.
Thanks. I mean, at the other end of the sort of conversation is that we really don't have good access to Pfizer at this point in time. So, I think that we should be encouraging those who've had a first, given that the data is safe, to have a second and be fully immunised under that schedule, rather than taking up, losing something in going to Pfizer. I think that the trickiest conversation is around those people who really would like to be vaccinated, who are vulnerable for other illnesses, who are in that, 50, around the age of 50 and less. And that's really where we should be concentrating our sort of issues around what that is going to look like. And I suppose that's something at this point in time is an emerging picture, isn't it, Kerry, in terms of how much Pfizer you will have to be able to offer to patients, and where those clinics will be, given that at this point it isn't suitable for GP clinics, and we do need to do it through New South Wales LHD-led clinics.
Look, I think that this is a matter that the Commonwealth is going to really grappling with as we speak. I mean, the Commonwealth has procured extra Pfizer doses and announced that last week, and so there is a lot of that Pfizer vaccine that will be available. But I understand that currently, and this is just in the public remit, what's been said publicly is that it's likely to be more towards the second half of the year. And so there's going to be timing issues. This is a massive planning exercise. And I think we've probably got to plan what we're doing for the next 4 to 6 weeks and then beyond. And we get new information all the time. And there might also be new entrants to the market. For instance, Novavax may become available at some point in 2021, may not, but that's why we've got to continue to keep a very flexible and agile considerations of the rollout. I don't know if you wanted to talk about Novavax, Kataki.
Before we talk about Novavax, can I just quickly say that the conversation will also change if we actually do get more community infection, because that will actually bring a sort of a level of, we need to get people vaccinated. And so maybe people who are saying, well, I don't want to have AstraZeneca, might need to, or might want to also consider, reconsider the role of AstraZeneca for themselves.
I mean, look, that's clear, Charlotte. I think clearly that is one of the challenges that ATAGI expressed, is they were giving this guidance in the absence of a crystal ball to see at what time we're opening borders, at what time we were going to get incursions, at what time were we going to get explosive outbreaks. They're likely to be patchy. All of these unknowns, and all we can do is genuinely inform our patients of what we know and the uncertainty around what we don't know. And I think that's probably something we need to communicate going forward, is some of this uncertainty about the future, and the fact that inevitably at some point in the future, once our border protections are not as robust as they are now, we are going to get circulation, we are going to get exposed to COVID. And there are many uncertainties about the timing of that. And hopefully the majority of the population of Australia will be vaccinated with highly effective, safe vaccines by that time.
I'll just add on the point of Novavax that it is a very promising vaccine, but they still haven't even published their phase 3 results, and it hasn't yet been approved in any country. And, we've seen hiccups with other vaccines. And so if I would just caution against patients necessarily just waiting for a better product when, as you've mentioned, there are so many uncertainties about that. And in the meantime, they may have, risks of exposure. So the benefits of, if they've had their first dose, for the people who've had their first dose safely, they should be even more reassured, because they can see that it's never been reported after a second dose. And for those people that are sort of around 50 and wondering, though, they might be the group for whom this the graphic resource that ATAGI is developing will be particularly useful, to just actually have a look and see what is their individual risk of exposure. If they work from home and they live alone and they really do have a low risk lifestyle, maybe they can justify waiting for a vaccine that they perceive to be safer. If, for example, they work out in the community, they're face-to-face with people every day, and they have a medical condition. You know, I as a provider would probably encourage them more towards vaccination, acknowledging this is an extremely rare side effect, and we do take those chances every time we take any medication or any vaccine of extremely rare side effects. And also that now we know how to detect and treat it. Hopefully we'll see the outcomes improve for this. So sorry, I've deviated a lot from Novavax, but I just think it's there's a lot of uncertainties. We can't quite just say, yep, just wait a couple of months and we'll be able to get Novavax.
And Kataki, can I ask if there is any other vaccine on the horizon, just to clarify that?
For Australia, well, Australia is part of COVAX, so that means we could technically have access to, I think, 25 million doses of other vaccines, including Moderna, through the COVAX facility. But obviously, and it's sort of a good thing, we're not a high priority country given our epidemiology currently and given that the fact that we have other agreements. But yes, we do have access to other vaccines through that. And also the TGA has granted provisional determination to Janssen as well. So.
Can I ask, I'm just this is a personal question actually. Do we know what effect this is going to have on Papua New Guinea and Timor-Leste, those sort of countries that are really suffering at the moment?
Yeah, I think for those countries, the risk-benefit assessment is completely different. And we can see, you know, even just the difference between the UK guidance that their cutoff was 30 because they have more circulating COVID, for example, whereas we were able to make that cutoff much higher because of our current epidemiology. When you look at PNG and Timor-Leste at the moment, the risks are clearly minuscule compared to the risks of COVID. So I think hopefully that public messaging can get out and vaccine confidence isn't impacted too much. But when you look at those high exposure scenario charts, it's clear that everyone should be getting vaccinated. And unfortunately, there's no sort of perfect option, but that is clearly the right option in that context.
Sorry, I'm laughing at the dog behind you, Kerry. Do you want to tell us a little bit more about how different is Novavax from the other ones on the market? So what are the advantages of that if it does end up being?
So Novavax is a protein-based vaccine. So I think that's a positive in that we're all sort of used to protein-based vaccines. It's a much more standard format, but it does have a new adjuvant in it. So that's a new product, a saponin-based adjuvant that increases its immunogenicity. Also 2 doses, and its efficacy looks quite good. So similar to what we've seen with the Pfizer vaccine. We obviously don't know how long the duration of protection would be from Novavax. With all of these sort of subunit or protein-based vaccines, protection tends to be shorter lived than, for example, a live attenuated vaccine. But it certainly looks to be, it's a platform that we would expect to be safe and very effective. And so I think it's fantastic that we have an agreement with Novavax. And the press releases that they've made have all been very promising, but we haven't yet seen the actual published phase 3 data to go in more depth about the safety and efficacy.
So there's a number of questions here, and I know you can't answer this, but there's a number of questions coming up about how do GPs access it, or how do we access the Pfizer, and they're still coming up. So I guess I just want, maybe Kev, you could reiterate that we're still in the...
So the Commonwealth is thinking about the impact of this ATAGI announcement on how the program is recalibrated. Clearly, we recognise there needs to be some changes to the program rollout. The Commonwealth is leading the program rollout. The states are here to help. So we are likely to, we did provide some comments and thoughts, but in the end, the Commonwealth is got to, I suspect in the next few days, there will be more clarity. I think we just need to remember this announcement happened on Thursday last week, and it does require a lot of work to actually think about that recalibration and then engagement. I recognise the uncertainty is part of the challenge for GPs, because you'll be getting asked these questions. But I would anticipate that we will get some clarity soon, because clearly that it is a major issue to get that certainty. But I suppose I'd want to indicate that I think this will be, and we'll have to continue to evolve our vaccine policy. As I said, Kataki's indicated that there may well be more better thermostability data, or new versions of the Pfizer product, which allows us more flexibility operationally. Novavax may come and be TGA registered at some point in time. So we again will just need to look at using what available vaccines we have in the most, provided they're safe to be used in the way we're using them, in the most effective way. And as I said, we're still in the prioritisation because the Pfizer is still at the moment quite limited relative to the AstraZeneca supply. So we are still going to need to prioritise Pfizer for the groups we need. And for us, that is continuing to protect our borders, our healthcare workers who may be caring for people with COVID, and then obviously the mortality impact is going to be greatest in those elderly and those with comorbidities.
Thanks, Kerry. And I guess the other thing I'm working in a GP respiratory clinic at the moment. I keep expecting that to sort of wind down as the vaccine comes up. But I guess we also need to continue to think about ongoing testing and surveillance, and well into the end of this year and maybe earlier into next year.
Clearly, we still need that testing, and I think it just highlights the fact that there was, a young gentleman in Queensland that had a sore throat and managed to get, and went off to get a test. Now, how amazing, a 26-year-old male who went off and got a test after having the sore throat for a few days. Now, if that person had not got that test, there might have been a whole string of transmission. The other person was, a healthcare worker, so you'd expect them to have a lot more awareness, and the second cluster, got detected. But to some extent, all of our incursions have relied on those amazing individuals presenting for a test. And yes, that's going to be part of our future, because whilst we are doing everything we can to learn more about protections in hotel quarantine, although we're vaccinating our quarantine staff and the households of the quarantine workers to provide those rings around it, we still are likely to see, notwithstanding occasional cracks in our system. And that's the unknown that we have.
I must say, working in the clinic, one of the things I would love to see is I'd love to be able to give a medal to everyone who comes in. I don't know if that's possible, Kerry. People coming in again and again, and they don't need to. And then we see other people coming in who go, I'm just here because I need to see a doctor. I can't access a doctor, but I don't want to be swabbed. And so, you've got you see a bit of range of human behavior there. But if you ever think of wanting to supply medals to those of us working in the GPRCs, I would love that. Give them something positive to take away.
Well, I think my colleague, Chief Health Officer in Queensland, called them heroes, and I think that's correct, because if we didn't pick up those cases, you can see how, someone who's infectious attending a, party, and even though they might be asymptomatic at that time, you can see how that sort of close, particularly indoor close environments, we can see many cases. And then it's quite easy to conceive of a few generations of lost transmission, and you end up with, quite an extensive community transmission.
And we had a conversation before we started about the testing, and Penny, you talked about the fact that the tests are much more patient friendly now than they were, but we'd also had a question come in about easier tests. Are there any going to be looming? So I suppose I'll pose that into the public forum.
So I suppose just in terms of easier tests, the challenge is that in an environment where there isn't much pre-test probability of having COVID, then you need fairly reliable, accurate tests, because we're actually trying to find that occasional case amongst many negatives. And unfortunately, the current testing regime is the most accurate. So the point of some of the other point of care tests or other things, or the antigen-based tests, are not as effective. notwithstanding, we are also using sort of passive surveillance through our sewage system as another sort of surveillance method. And I've got to acknowledge the work of Sydney Water. It is actually really quite accurate. And we've been very pleased with that. And it certainly does give us quite an added degree of assurance, particularly across regional areas where there's much smaller sewage catchments. But we've also done a lot of work to segment the Sydney catchment into smaller catchments. Again, we haven't got the sensitivity to pick up one case, but probably if there was a cluster and multiple cases in those Sydney catchments, we would be able to detect the sewage as well.
Can I then move us slightly sideways with testing? One thing I know that Jeremy McAnulty had we put out a press release last week, and I think it's worth talking about the request for people not to get patients tested for their immunity post-vaccination. And maybe if we could talk a little bit about that. And as well as that, the need to, we will still continue to need to test people for COVID swabbing, even when they are fully vaccinated, if they present with symptoms that do fit the bill for COVID testing. Do you mind covering those topics?
Yeah, so at the moment, the real indications for serology are a part of, I suppose, diagnostic investigations where you're actually trying to exclude old COVID as a cause of any lingering complications in that clinical context. And also for public health, we use serology to identify missing chains. If we've got to them too late, they could have cleared the infection, and so the nasopharyngeal swabs don't detect it, but we take blood on and do for serology to map that transmission chain. And you've seen probably recently with Queensland where they've identified the sort of lines of transmission through the upstream testing, a lot of which has been serological. So because of that, there really isn't an indication to test everyone post-vaccine for antibodies. And if you do, we're going to have to ring you to find out why, because, you know, we are concerned that someone inadvertently has done a serological test which is positive and the person may have had COVID. So one, it's probably not a clinically appropriate test to test everyone for their vaccine status. And the second component is it generates a lot of work for public health because we have to follow them up to check that there's not a missing cases of COVID that we've diagnosed. So, so that's that. And then going forward, look, our testing strategy will evolve going forward. Eventually, at a time when we have vaccinated everyone, we have accepted that we'll have some community transmission. Then again, we've got to say at that point, we won't be trying to find every single case of COVID. We will then be switching to the normal way in which we probably manage respiratory illnesses, is where it has material difference for either public health action or individual patient action. That's when we test them. So the paradigm, there will be a paradigm shift in the future, but at the moment it's so far away, we're probably not there yet, but that will occur.
Kerry, can I ask at what stage of or what percentage coverage that might happen, or is that a bit of a tricky question?
Look, I think the current thinking is because we haven't got a vaccine that's licensed for the 12 to 16s or the children, and although children don't transmit as much as adults, particularly those under 12, but we do know the 12 to progressively the 18-year-olds do transmit. And because we'll have a significant number, even when we've offered the vaccine to every Australian, there will be enough unprotected people, be that if we have not had a vaccine that's licensed at that stage for the 12 to 18-year-olds. So it's likely that we'll have the recommendation from health is that we actually try and get as many people offered the vaccine before we start seeing COVID COVID circulating, so that we've had that opportunity to get all our vulnerables, all our elderly, and offer everyone vaccine. But that's one perspective, that's a health perspective, and in the end there'll be multiple perspectives put to the table. But we know that that will be essential, and even in that time, in that setting, we would still believe we would see significant clusters of cases and an impact.
And I just want to go backwards now to the conversation about swabbing, which is dear to my heart. We put a lot of effort in. We see a lot of children, obviously, in the respiratory clinics, and we do a lot of work trying to distract and getting them to wiggle their toes and bouncing up and down and spinning around and doing all sorts of things. I just want to reassure GPs that actually aren't working in these clinics or aren't doing any swabbing, is that the swabs are now quite small in comparison to the ones that were originally being used and being pushed right back into the head. We're only going 1 to 2 centimeters into the nose and rotating both nostrils for the children, and we're going 2 to 3 for the adults, and we're doing the oral cavity as well. So a lot of children can be quite easily distracted. There's always going to be some that can't, but I mean, I think if we can, there's a lot of work going into trying to make it more pleasant. Obviously, it's always going to be a difficult thing to do, but I think it has improved since it originally began. And a lot of the stories we hear about it, I think, are coming from those people that had it done many months ago. Kataki, I was wondering if we could sort of just move a little bit towards the flu season, and what your thoughts are. And I know there's been a few webinars on flu season, but what your thoughts are about what the likely flu season might be, or what we're seeing so far, and I guess a little bit about vaccination and flu vaccination and COVID vaccination.
So I'm not across what our current flu season has been so far, but hopefully we'll be, along the lines of last year and not see very much at all. But in terms of vaccination, there are a couple of guidance documents that you may have already seen regarding the timing of flu vaccine this year in relation to COVID vaccine. I thought that might be useful to touch on in planning with your patients which one to give first. That it is recommended if they have a risk factor for COVID, or if they're in a high risk of exposure for COVID, we recommend to prioritise COVID vaccine first. And otherwise, of course, they should have their flu vaccine first. But I wonder if I can throw to Kerry for an update on this year's flu season.
Yeah, so pleasingly, flu has been incredibly low levels. So that's been, the border measures have been effective. We haven't seen any circulating flu at any levels, any significant levels. What's been interesting is we've certainly dispatched millions of doses of vaccine out to GPs, and I hope it went smoothly. We will have a debrief at the end of this flu season to see how that went, but thank you very much for your patience. We did try and distribute to regional GPs first, and then noting that the supply chain for the metropolitan was much shorter. So hopefully that has been positive, but again, we're happy to learn how to do it better next flu season. But when we looked at the air this morning, there'd been 277,000 doses given of flu vaccine in New South Wales. So I think probably the bulk of that would have been given by GPs. So can I congratulate you on your efforts so far?
Yeah, I think it's been a really good opportunity, certainly in my practice, and I've heard around the traps too, Kerry, to have a good debrief about the COVID vaccination program as well, and give people a bit of breathing space while we sort of get the numbers into general practice. Because as we all know, the biggest issue really with the COVID vaccine for GPs has been the very slow dribble of vaccines into the standard practice. Though we know that there's been a lot more numbers of vaccine going into the respiratory clinics, but from a standard general practice perspective, that's been a really good way of getting things done, because we've got to do flu anyway, got to give it 2 weeks apart. So thank you for facilitating a smooth rollout of that. So we've got that to sort of head into the winter with.
So a couple of questions coming up here. One is, should we be giving the flu now? Should we be waiting till May? And then the other question linked to that is, should we be testing for flu when someone presents with flu-like symptoms and presents for a COVID test? I don't know, Kerry or Kataki, if you wanted to comment on that.
Kataki, do you want to go ahead with the guidelines for when ATAGI says to give flu vaccine? But
so I think carry on, and I would give the flu vaccine now if it's available now. And you know, you never know if patients will turn up again, and it's sort of too hard to predict. I know in previous years people have been concerned about if the efficacy wears off and later on in the year they may therefore have a higher risk. But I think the priority is to vaccinate when available, and then that also increases their chances of being able to get a COVID vaccine scheduled in within the next few weeks.
And then my question about your comment about the testing, I think again it goes to the issue of the clinical appropriateness and would you act any differently knowing it's flu or anything else. And so if flu will change your management of a patient, then certainly request it. If not, then I would suggest not to do so. I should just say that a number of the platforms, though, have multiple do them automatically, and so again, look at what your provider normally does, because if they run the full suite of platforms, then obviously the results will be available to you for the full respiratory panel.
Can I just, final clarification, Kerry, there's been a couple of queries around the aged care facility staff and, you know, the Pfizer vaccine. For some, there's been a couple of issues where we know some staff got one Pfizer and then didn't get the second one when their practice. So how can we facilitate?
So if you want to email, we'll communicate how to email in to get them vaccinated, but we will vaccinate them at our Pfizer hubs or facilitate that vaccination for the second dose. If the aged care staff have got the one dose, we'll certainly make available the second dose, if at all possible, for them.
Yeah, we've heard stories of people being turned away. So I think if we can have an assurance that we can facilitate that, that would be fantastic. And in the meantime, just trying to access the aged care facility staff to a Pfizer if possible, especially if they're less than 50, and otherwise just to a respiratory clinic.
So Charlotte, what I might do is tomorrow I might get somewhere where you could email the details in of the individuals, and then we could follow up with them in terms of how they could be referred to a Pfizer hub, depending where they are. Obviously, we haven't got Pfizer hubs geographically everywhere, but provided there's one accessible, we'll try and make arrangements.
Terrific.
Yeah, I think that's one of the confusions with GPs is being how to access those things. So I think that would be wonderful.
As we try and make sure all questions are covered, do you have anything? Otherwise, we're getting close to the end.
I think there's one question here around how long the immunity is thought to last for AstraZeneca and for Pfizer. Kataki, did you have a comment on that?
Yeah, actually, I responded to one comment saying that this is something that they'll follow up with the clinical trial participants at regular intervals. For example, at 6 months after dose 2, 12 months after dose 2. And that should give us some really useful information on the persistence of the antibody levels. So some vaccines, you see that they fall off steeply. Moderna just released their results showing that at 6 months, the antibody levels were still really high across all age groups. So hopefully Pfizer, being a similar platform, will have a similar result. But we don't have that data actually yet for Pfizer or AstraZeneca vaccine.
There's also been a request for your slides, Kataki, or Christine's slides. So I know they're not your slides, but it's up to you. I don't know whether you're able to.
Yeah, I'll ask Christine. I'll ask Christine if I can share them, and I'll email them to Beth.
And so if that's the case, then I know Beth will make sure that that's accessible to all attendees.
Yeah, I'll send a follow-up email once I've received those, if I can receive those, and yeah, get those out to all the participants.
So I think we are handing over to Beth now. I think we're just about up time.
Perfect. No worries. Well, just before we head off, I would just like to say a massive thank you to our presenters, Charlotte, Kerry, Kitaki, and Penny. As always, it's been a pleasure. And thank you to everyone online for your questions. I will email out those resources as just mentioned, as well as the details for the next webinar as well. But thank you again and have a lovely evening, everyone.
Thank you.
Thanks, everybody.
Thank you.